Welcome to 5 spotters with multiple choices. You can choose one or more of the choices to give the correct answer. I'm giving the first question. This is X-ray PNS in Waters view. Now I'll give you the choices. Is there a polyp, or is it due to mucormycosis, or is there a rhinolith, or is there deviated nasal septum? The choices are either polyp or mucormycosis or rhinolith or DNS. I'll give few seconds and then we'll go for the findings and the diagnosis. So this is a middle-aged man with history of left nasal obstruction for 2 to 3 years. You can see a well-defined radio-opaque lesion in the left inferior nasal cavity with central lucency. I think the arrowheads in blue arrows, you can see that. The lesion is separate from the adjacent nasal walls, the palate and the teeth. Now you can think about the differential diagnosis. The mnemonic is LINT, L-I-N-T. L is for lith, where you can have rhinolith or mycolith. We have given rhinolith as a DD, as a choice. I is infection, which can be calcified tuberculosis or fungus. N is nasal tooth, which can be supernumerary or unerupted tooth. T is for tumors, which can be calcific or ossific and which can be benign or malignant. So again, the diagnosis is rhinolith with central lucency. You can see it very well. The radiographic features are very much sensitive or suggestive of either supernumerary nasal tooth or rhinolith. Rhinolith was diagnosed on clinical examination and after nasal endoscopy by our ENT surgeon. The X-ray PNS was then done to see its size and extent. It was removed surgically. Rhinoliths are rare and sometimes incidentally discovered in X-ray and nowadays in the CT PNS many times. Some patients complain of purulent, painful rhinorrhea, ipsilateral nasal obstruction. Other symptoms include fetor, epistaxis, sinusitis, headache, and in rare cases, epiphora or anosmia. Erosions of the nasal septum, maxillary walls, and perforations have also been cited in the literature. Rhinolith is calcareous concretions formed by deposition of salts on intranasal foreign body, which is the nucleus for incrustation. The foreign body may be endogenous, which might be desiccated blood clots or mucus, ectopic teeth, sequestra, and bony or bone fragments. Exogenous foreign body can be fruit seeds, plant material, beads, cotton wool, and dental impression material. A number of factors are thought to be involved in the formation of rhinoliths. The first one is the entry and impaction of a foreign body into the nasal cavity, which might go for acute or chronic inflammation, and then it might go for obstruction and stagnation of nasal secretions. And last one is the precipitation of mineral salts. Development and progression are believed to take many years actually. So the diagnosis here is rhinolith. Now we'll go to the second question. This is X-ray forearm focusing the wrist in AP and lateral views. There is a fracture. You have to think about the type of the fracture. The choices are, is it Colles fracture or Barton fracture or Smith fracture or Bennett fracture? Analyze well, and what do you think? Is it Colles or Barton or Smith or Bennett fracture? We will describe about the findings in the given image, then we'll give the final diagnosis. The left AP view shows a small fragment in the radioulnar region with loss of radiocarpal joint space. You can see the arrowheads. The right lateral view shows distorted ventral rim of distal radius at radiolunate joint space. Again, you can see the arrowhead. Sagittal reconstruction CT wrist showed clearly the comminuted intra-articular fracture of the distal radius with dislocation of the radiolunate joint. You can see the fracture fragments can be seen in the later. Marginal comminuted intra-articular fracture in the medial palmar aspect of distal radius separating the anterior radial rim with ventral proximal dislocation of radiolunate joint. This is called as anterior marginal intra-articular fracture of the distal radius, otherwise called as ventral Barton fracture. You can see the normal anatomy of the X-ray wrist in lateral view, and you can see the dorsal dislocation as the ventral dislocation. In our case, it is the ventral dislocation, anterior marginal intra-articular dislocation of radiolunate joint. Now we can differentiate anterior and posterior marginal intra-articular fracture of distal radius. Anterior marginal intra-articular fracture of distal radius is otherwise called as volar Barton's fracture, which is our case. Otherwise also called as marginal Smith's fracture with intra-articular involvement. It's more common in young adults in road traffic accidents. Usually there will be more volar rim fracture with ventral dislocation, might have carpal ligament injury. We'll go to the posterior marginal interarticular fracture of distal radius, which is otherwise called as dorsal Barton's fracture, otherwise called as marginal Colles fracture with interarticular involvement. It's common in old adults in simple injury actually. There will be dorsal rim fracture with dorsal dislocation. Again, the same carpal ligament injury might complicate. The complications of any due to malunion, due to radial shortening and angulation, and second one is inferior radial nerve joint subluxation or dislocation. Reflex sympathetic dystrophy is a complication, and you might have tendon rupture, and later you can have a early osteoarthritis. And it's very important to note that few authors or articles have used reverse Barton's fracture as synonymous to Smith's fracture. Hence, reporting of this case as reverse Barton's fracture might be misleading, right? We'll go to the third case. This is ultrasound image focusing the gallbladder with the findings giving the choices now. Is it due to cystic lymphangioma, or is it due to viral hepatitis, or is it due to COVID, or is it due to Caroli's disease? So cystic lymphangioma or viral hepatitis or COVID or Caroli's disease. So what's your choice? Think about it. Now we'll go for the findings and discussion. This is a 45-year-old healthy lady for health checkup. She came for health checkup. An ultrasound gallbladder revealed multiseptated cystic pattern anterior to the GB wall with no calculi or calcification. The gallbladder is not displaced and is not compressed by the lesion. And we did the ultrasound was unchanged even after heavy fatty meal. I'll give you the. So postprandially there was no change in the gallbladder. So the differential diagnosis, any of the causes of GB wall thickening you might think about: viral hepatitis, cholecystitis, dengue, multi-organ failure. Second is multifolded multiseptated gallbladder. That's again can be seen. Intrahepatic septated cyst might also be thought of. The fourth one is pericholecystic tumor, and fifth one is cystic lymphangioma of gallbladder. That's the diagnosis. Here, lymphangioma are uncommon benign congenital malformations of the lymphatic system. It can be seen in any part of the body except brain, which due to absence of lymphatic system intracranially. 95% of lymphangioma occur in the skin or subcutaneous tissues of the head, neck and axillary region, and the remaining 5% appear in other parts of the body such as lungs, pleura, pericardium, esophagus, stomach, jejunum, colon, pancreas, liver, kidney, mesentery and gallbladder last. So cystic lymphangioma gallbladder are classified histologically as simple, cavernous or cystic types. GB lymphangiomas can be incidentally detected in children, adolescents or in even adults. Less commonly it may be symptomatic due to obstructive jaundice by either CBD compression or IH obstruction or due to GB neck compression. Secondary infective etiology like viral hepatitis or viral pneumonia might precipitate the symptoms. Complete resection by surgery or laparoscopic resection is the treatment of choice in symptomatic individuals. I'll talk about cystic lymphangioma in the fetus in this year because the prominent lymphatic system is seen in the posterior neck in the fetuses from 11 to 24 weeks in all the fetuses. Its thickening indicates either chromosomal or non-chromosomal congenital defects. Transient nuchal translucency can be seen in the 11 to 14 week nuchal translucency scan, and transient nuchal fold thickness can be seen in the second trimester up to 24 weeks. But persistent cystic hygroma or nuchal lymphangioma is abnormal either due to chromosomal defect or non-chromosomal congenital defects. This has to be thought of in this era, right? Now we'll go to the fourth case with the given images. What's your choice? So I'm giving the choices: Sigon fracture, Hoffa fracture, or is it due to Cox tuberculosis, or is it due to Osgood-Schlatter disease? In the beginning of the quiz, I meant to choose the right answer, bracketing the yes in the answers. The answer might be one or more. Please give your time and think about the answer. Within few seconds, we will discuss about the findings and the final diagnosis. So this is CT coronal reconstruction of knee in a 58-year-old man injured in a road traffic accident. The left side image shows avulsion fracture in the tibial contour at the femorotibial joint region. The right side image shows fracture line in the posterior edge of the femoral condyle. If you connect the dots, we know that Sigon fracture is the avulsion fracture in the lateral tibial contour. Unicondylar coronal intraarticular fracture of the lateral femoral condyle, which you can see on the other side, is called as Hoffa fracture. CT topogram revealed irregularity in the external contour of lateral tibial condyle above the tibiofibular region with significant soft tissue thickening around the lateral contour of the knee. You can see the image. CT axial sections on the other side reveal avulsion fracture in the lateral tibial condyle with genu varus deformity of the femorotibial joint space. Additionally, there is unicondylar coronal fracture in the posterolateral aspect of lateral femoral condyle with intraarticular extension. Unicondylar coronal intraarticular fracture of the lateral femoral condyle is called as Hoffa fracture, and avulsion fracture in the lateral tibial contour at the femorotibial region is called as Sigon fracture. So we have got both Hoffa and Sigon fractures. Hoffa fracture is an intra-articular fracture of the femoral condyle. Unicondylar fracture is more common than bicondylar fracture, and lateral femoral condyle is being more common than medial condyle. This fracture is always missed in X-rays and is picked up or incidentally detected in CT or MR in acutely injured knee. Sigon fracture is an avulsion due to injury at the insertion of lateral capsular ligament of the lateral tibial plateau. It's commonly associated with anterior cruciate ligament tear and medial meniscal tear. Hoffa fracture is less common than other distal femoral fractures. It is coronally oriented unicondylar or bicondylar fractures of the distal femoral condyle. Hoffa, a German orthopedist, was the eminent specialist in 1900s in knee orthopedics. His name is being used Hoffa's fat pad, Hoffa's sign, or Hoffa's test, Hoffa's disease, and Hoffa's syndrome, etc. We'll go to Sigon fracture, which is described by Sigon, a professor of surgery at the University of Paris, chief surgery. This fracture is important due to associated internal derangement injuries, especially ACL tear and medial meniscal tear. A reverse Sigon fracture has also been described later as avulsion fracture in the medial tibial plateau and is associated with tears of the posterior cruciate ligament and medial meniscus. Coming to the last case, the fifth case, by the given image, what's your diagnosis? With the choices of chronic rejection, renal fatty replacement, pelvic kidney, renal sinus lipomatosis. Now you can think about the choices. You can choose one or more than one diagnosis. Within few seconds, we'll talk about the findings and the diagnosis. This is about asymptomatic 56-year-old man who had transplant kidney 3 years back with annual follow-up. Ultrasound revealed hyperechoic lesion in the entire central portion of the kidney extending extrarenally. We suggested CT to rule out the hyperechoic mass in the entire central portion of the transplant kidney extending extrarenally medially. So it's a transplant kidney is seen in extraperitoneal space of right iliac fossa with fatty deposition of the entire renal sinus. It is also extending extrarenally around the renal hilum. Parenchymal thickness appears preserved with no evidence of scarring. There is no calcification or mass formation. There is no evidence to suggest obstructive nephropathy. There is no hydronephrosis. So the differential diagnosis is either renal sinus lipomatosis or renal replacement lipomatosis. So now we'll discuss about differences between renal sinus lipomatosis and renal fatty replacement. Renal sinus lipomatosis is due to obesity or due to steroid intake or Cushing's syndrome, or it can be idiopathic, and it causes proliferation of renal sinus, which is fat with preserved cortex. Parenchymal thickness will be well preserved because the renal function test will be normal usually. Whereas we'll go to the renal fatty replacement, it means renal destruction or obstruction as in rejection, which is more common, or it can be due to stricture obstructive uropathy. Causes atrophic changes with the parenchymal thickness will be very much reduced, and it is almost replaced by fat, and it is always managed by surgery or dialysis because the renal function will be deranged. So the final diagnosis is renal sinus lipomatosis due to obesity and chronic steroid intake in a normal transplanted kidney, right? We are almost in the end of the session. Few days back this has been posted as a quiz. I congratulate all of you who had participated in this quiz. Dr. Chetan Vaishnav, Dr. Paresh Dedia and Dr. Raghavi scored 90% and they are near superstars. Dr. Kadir Baksh, Dr. Lakshmi Narayanan, Dr. Jai Chandra Bose are the shining stars of the quiz. Dr. Atik Ahmad doing anesthesia, and another unnamed consultant radiologist, and Dr. Gopinath, who are the singing stars of the quiz. I congratulate all of you who have participated well. Thank you very much for patient hearing. Please share with your colleagues and give your comments. Don't forget to subscribe and to update this channel. All the best in all your endeavors. Take care and bye bye.